Thank you very much. It is absolutely wonderful to be here. It's interesting as Annie talks about how inspired she gets. I want you to know this is what inspires me. Coming here, knowing what we're working for every day, who's impacted, who's involved. This is important. This is what we do, why we do what we do, and so I'm just honored to be here. I really want to thank Terry Yoder and her team for putting this together. You know, making a successful program is really difficult, and it's really terrific that we get to do that. You have a terrific chapter and guild here in the Pacific Northwest, and really thank them for all their work. I also want to thank you. As I know, many of you, I look around and I see people and faces that I know. So how many of you already participate one way or another in clinical research, have been part of something? That's pretty amazing. So thank you. Thank you very much for doing that. What I'm going to do today is talk about stages of diabetes, and it's going to be framed in the idea of TrialNet. So Diabetes TrialNet is really the organization that is sponsored by your tax dollars, but also JDRF plays a big role in this. And as you'll see in a minute, it's an international organization trying to find that cure and prevention of diabetes. So I'm going to talk a little bit about who TrialNet is, what we do, the path, that is the stages to diabetes, and then what is it we're trying to do to stop those stages from progressing. So who are we? We're an international group. So this is the Scandinavians, people in Australia, Germany, Italy, the UK, Canada, and the US are all involved in this network. And the idea here is that, as I mentioned, we're funded by the NIH, and the idea is to say, can we find a way that we can stop the progression of this disease, preserve insulin production? So we're going to use the knowledge that we have gained from the research, because our mission is to prevent and to stop further progression of that disease. I want you to know that when Annie joined us at Benaroya, she had been working for a long time with JDRF and other places, she said we needed a better mission statement. So this is, she's really led a lot of this, and I'm like, well, why do we need a mission statement? We kind of know what we want to do, but she's right. It's very helpful and impactful to be able to clearly state, what are we doing? What are we doing every day, day in and day out? So one of the things that has been a big change this year that we're rolling out is the stages of diabetes, and that's really the most important thing I want you to learn from the talk today. So when we think about the stages, I'm going to go through each page, but this is the path to diabetes. These are the different steps that I want you to understand that we can now describe because of the research that's happened over the past 20 years or so. So let me go through. We start in this path with genetic risk. So what does it mean to have genetic risk? Oka's already described to you about the HLA genes and potentially why those genes are so common in people with type 1 diabetes. But what does that mean? How many people have genetic risk? Well, we know 1 out of every 300 people will get type 1 diabetes. That's the risk in the general population. However, if you then have a relative, then the risk is much greater. It's 1 out of 20, so that's 15 times more people are at risk if you have a relative. So why is that? Well, basically, because you pass genes within your family, right? So you have a concentrated genetic risk, and as a result, 1 out of every 20 people who have a relative with type 1 diabetes will develop this disease. The next stage, once you have genetic risk, is what we call immune activation. Something triggers the immune system. We don't yet know what that is. Oka gave you the idea about this idea that the beta cell's infected and the T cells are trying to swallow that up. And there's a tremendous amount of work with Teddy and other studies to try to understand what is that first step. But something happens in the people with genetic risk who get that first step of immune activation. It's probably a common event, and there is a lot of research going on this way. So there are many people who have genetic risk who get this immune activation but do not go on to the next step to progress into diabetes. So this is just a piece of that whole puzzle. What about the next step? The next step is the immune response. So this is you had genetic risk, you had something activating you, the immune system notices that there's something going on and makes a response, an antibody. Again, as Oka said, up to you. There are many different types of antibodies, but that's the initial response to this immune activation. So the immune system is responding to beta cells being attacked. It results in the development of antibodies. And these are the visible signals that something's going on in your pancreas, because we can't look at your pancreas as the day is going on. What about the next step? When you have the immune response, you're getting a development of a single antibody. So as I mentioned before, everybody who gets type 1 diabetes had genetic risk. Some of those people will have the immune system being activated. You notice on our step there's less people. The next step, even fewer who have gotten that activation will go on to get antibodies. Now each one of these steps, you note we step down. But those of you that are paying close attention can see that the bottom line now there's no step down, right? So the top step, not everybody goes to the second. From the second step, not everybody goes to the third. But once you've gotten to the next point, there is no change, because type 1 diabetes starts when you have 2 or more autoantibodies. And in a minute, I'll explain that a little bit further, and what those different stages are. So that is really new information that we have gathered over the past 20-some years or so. This is actually, you don't need to read the small print here, but just the notion that this is not just my idea sitting in Seattle. This is really now becoming accepted everywhere. So the American Diabetes Association, the Endocrine Society, the Juvenile Diabetes Foundation are all making this as a scientific statement that this is really the start of type 1 diabetes. So let's go through the stages. The first stage of diabetes, when you're first on this line, is when you have normal blood sugar, 2 or more antibodies, and you still have lots of beta cells. This picture is lots of beta cells, by the way. That's not what beta cells really look like, but it gives you the idea. Okay. So you have the beta cells, and you have 2 or more antibodies, and you have no symptoms. Blood sugar is completely normal. We do a glucose test, and we find it's completely normal. But yet, once there's 2 antibodies, that disease has started down that path, that track. What about the next stage? So now you're still on that same path. You will progress from the stage 1 to stage 2 if we don't intervene in that process. Once again, 2 or more antibodies, you have fewer beta cells. So there's still enough there that make you not having any symptoms or feel poorly. But if we actually test what's going on with you, we measure your glucose, it's not normal anymore. So it's not so abnormal that you feel lousy like Annie does this morning, but it is not normal anymore. So we call that stage 2 of diabetes. 2 or more antibodies, abnormal glucose, but no symptoms. You feel fine. What about stage 3 of diabetes? Well, stage 3 is what we used to say when diabetes starts, right? That's what you're all familiar with. That is clinical type 1 diabetes. That's a diagnosis of diabetes, formerly known as the start of diabetes. At that time, you have even less beta cells that are functioning, and of course, that's when you get the symptoms of having high blood sugar. So I know it's kind of awkward to tell people, I just entered stage 3 of diabetes, right? It's much more obvious to say, this is when I got disease. But hopefully you all will leave here knowing that that's really not true. You started getting diabetes, or your loved ones started getting diabetes when there were 2 or more antibodies present. So I've outlined a little bit. The 4th stage now of diabetes is long-standing disease. So people that are not in that early period of time when they have it, but they continue to have continued loss of beta cells over time. And as I'll show you, we used to think that your beta cells are completely gone. We now know that's not true in many people, but the amount of beta cells that are left when you have long-standing diabetes in most people is very, very low. There's a lot of research that's going on that's not part of TrialNet right now, but we actually at Benaroya are involved in other people to try to find what we can do for people who have long-standing diabetes. But TrialNet is really focusing on those earlier stages of disease. So the second message, in addition to saying 2 or more antibodies as a start of the disease, is that age matters. So how many of you here, you or someone in your family was diagnosed in childhood under age 18? Okay. So that is actually, the stereotype is type 1 diabetes is a disease of childhood, and clearly that's true. But there are many people, such as Annie and her father, who are diagnosed in adulthood. But we now know there are differences. There's differences. And I love this little cartoon because what I want to show you here is that, remember, this is the stages of diabetes, 1, 2, 3, and 4, and the different ages, the very young and the different age groups. And if my animation works, we'll see. So as you can see, the rate of progression through every stage goes faster if you're younger. It sort of makes sense, right? If you got the clinical onset, stage 3 of diabetes when you're under 5, the earlier parts had to go faster. But all this makes a big difference when we think about what are the treatments we want to do. Because if I enroll somebody who's 7 years old in a trial, I'm going to have a very different expectation about their getting diabetes, progressing to the next step than somebody who is 28 when they have their antibodies. So age is a very important predictor of the rate you get diabetes, but it doesn't change the risk. The rate meaning how fast you progress, but the risk is the same once you have 2 or more antibodies. So to summarize, type 1 diabetes starts with 2 or more antibodies. There are 3 defined stages. Stage 1, when you have 2 antibodies, glucose is normal. Stage 2, 2 or more antibodies, glucose is abnormal. Stage 3, clinical onset of disease, and age matters. I'm going to transition a little bit to tell you one important part that JDRF has been playing on the importance of staging. I mean, why does it matter that we give it a new name, right? Many of you have been known for years. We tell you that antibodies predicting diabetes. It matters a lot. Let's say I'm a company and I have a new therapy and I want to be able to get my new therapy ready for clinical use. I need to be able to go and say to the FDA, my drug keeps people going from stage 1 to stage 2. And that's a good reason, an indication, a use of that drug. So industry really needs this information so that they see a path to be able to get approval for their therapeutics. Okay. JDRF has taken a big role in this, working with industry and academics to bring together and meeting with the FDA, just like they did 10 years ago for their artificial pancreas project, to make sure we see once the science gets there, there'll be a regulatory pathway to get these actually for people to be able to use. So that's why stages of diabetes is important. The other reason it's important is what we're doing today, is to explain more clearly to everybody what it means by having antibodies and the risk for diabetes. So those are really key and important parts. We also know that identifying type 1 diabetes at the early stages really does prevent people from getting acutely ill at stage 3 or new onset of diabetes. So that's a very important point of having stages of diabetes. And most importantly, and what TrialNet's trying to do is to stop that, right? To stop or slow those progression from one stage to another. So what kind of things are we actually doing? Remember, going back to our mission statement, right? We're trying to preserve insulin production before or after clinical diagnosis at various stages of the disease. And it starts with a program called Pathway to Prevention. And the little purple people here means that with the first step, you get tested and you find out where you are in this path, okay? You can actually, you or your family members can get tested here today, and I'll tell you about that again. But nonetheless, the first thing is a simple blood test to say, do you have antibodies or not? So we can figure out where you are on this continuum. It's no cost. Anybody who has a first or second degree relative. So many of you, if you had one child diagnosed, might have had your other child tested. But don't forget that child's cousin, right? This is a huge international study. Where everybody lives, they are at risk if they are related to somebody with diabetes, and they can be tested. With screening is for the autoantibodies, and then the results will tell us and tell you whether or not there's a risk there that makes you eligible potentially to be in a trial to see if we can slow or stop this disease. By the way, all these wonderful pictures are actual participants, and if some of you see your picture in here, I don't know if we have Seattle people, but everybody gave permission to have their picture. But obviously, all this research is really dependent on the fact that people have participated for decades in this kind of work. So anyone between the ages of 1 and 45 who has a first-degree relative, or 1 in 20 if you have a second-degree relative, you don't need to memorize that. We have people here who can help you remember what the age groups are. And that if, and this is an important point that some people don't recognize, let's say your child is 7 years old and you got him tested for antibodies and they were negative. Unfortunately, that doesn't mean you're done. Because even though, as Oka mentioned, many people develop their antibodies very young, right? We also know there are people who won't have antibodies at age 7 that might have it by age 10. So we do recommend for children to get rescreened every year to see if the antibodies are developed. Once you're an adult, once you're 18 years of age or over, we don't have you rescreened because it's not impossible, but it's a much lower risk of developing antibodies new when you're an adult. But make sure if you've already had your children or other family members tested, they still need to be retested each year to make sure they haven't developed it. So what is the studies that we're doing to try to stop this disease? As I mentioned, at stage 1 of diabetes, right, to start with your normal blood sugars. And for this study, you have to have a certain type of the antibodies. You have to have the insulin autoantibodies. And the idea here is to see if we can delay conversion from stage 1 to stage 2 to prolong stage 1, to keep people from moving on that path and maintain the current level of production. Why are we doing this? Well, we did a study back when I had no gray hair in the early 90s, where we tested to see whether this would work. And overall it didn't work, right? But when we looked at that information more carefully, there was a subgroup of people who seemed to have a very dramatic effect, perhaps up to a 10-year delay in getting clinical diabetes. So we said, we need to retest this, because that's called a post hoc analysis. It's kind of cheating, not really. But it means we have to do the study again, and that's why we're doing this. And I'm very excited to say the results of this study, which has been going on now for 8 years, will be announced at this year's American Diabetes Association meeting in 2017. So in June of next year, we'll know. I don't know either, right? I have no idea. I'll find out at the same time everybody else does. But for this study, people take a daily pill, and that's what the study is all about. So we're also doing a similar study in the same group of people. We finished enrolling everybody in that study about a year ago, but we're not going to have the results until next year. So we wanted to take advantage of that period of time to say, what else can we learn about how to give oral insulin to keep the beta cells from being further destroyed? And so we started a new study called the Immune Effects of Oral Insulin. Same group of people, right? Stage 1 and some people at stage 2 of diabetes. And the idea here is to learn how different doses may affect the immune system. So in our current study, the long-term study, we're giving a single dose where everybody's taking the same dose every single day. For this study, we're testing different doses of oral insulin and given in different ways. And that's going to give us the stepping stone to the next trial with these kinds of therapies. All right, what about the other studies we have? We have a study with a drug called abatacept or Orencia. Some of you might have seen the commercials on TV where they have the ladies with the butterfly, where they have rheumatoid arthritis. Anyway, I don't like that ad, but it's pretty funny. So there's no butterflies in this story, but this is a drug that's been widely used in rheumatoid arthritis and other diseases, and we're testing it in diabetes in people who have stage 1 of disease. And the idea, again, can we delay the conversion from going from stage 1 to stage 2 of disease? This is a great picture. But again, this drug has been used not only treating adults with rheumatoid arthritis, but children, and it's been effective. So we're very interested in testing this at people early in the disease. We already did a study in people at stage 3 of the disease with this drug, and it did delay the further insulin destruction after diagnosis. So we're hoping it's going to have a more profound effect earlier in disease, and that's what we're testing. So to reiterate, for stage 1, it's oral insulin that we're going to have the results next year, the immune effects of oral insulin that we also expect to have results next year, and the abatacept or Orencia trial that will still be a few years longer before we know the outcome of the study. What about stage 2 of the disease? Remember, this is 2 or more antibodies, but your glucose isn't normal. And here we're testing a drug called teplizumab. Yes, you'll get tested to make sure that you can say that 3 times. Okay. So what is teplizumab? It's a drug that affects the T cells, one of the parts of the immune system. And the idea is to see, can it delay conversion from stage 2 to stage 3 or clinical onset of diabetes and maintain the current level of insulin production? So why are we testing this? Because we've already tested this in a large number of people who have stage 3 or clinically onset diabetes. And in those cases, there was a delay in the destruction of the insulin-producing cells. So now, again, we're doing it earlier in the disease with the hope to see if we can get a more profound and a longer effect in preventing this disease. So for this stage of disease right now, this is the only trial that's open, and it's for people that are 8 years of age or over but are at stage 2 of diabetes. We also have studies at stage 3, so people that are newly diagnosed. This is, again, you're going to get quizzed, so make sure you get this down. Anti-thymocyte globulin and G-CSF. So it's a combination therapy that was tested in a small pilot study previously, and now we're trying to test it in people in a larger study. And the idea is to say, you already have diabetes, we're clinical onset diabetes, we can't make that go away yet, but can we keep the remaining insulin-producing cells there for a longer period of time? So the good news here is that, as I mentioned, we had done this as a pilot study, and now that we're testing it in a larger number of people, we expect to have those results again in about 1 year. So that study is fully enrolled as well. There is another study that is open here in the Seattle area, which is testing a different drug, tocilizumab. Currently, that's only for adults. So people that were adults and diagnosed within the last 3 months with clinical type 1 diabetes are eligible for that study. We're in conversations with the FDA to be able to do that in children as well, and I'm hoping we'll know that in the next few months about that study. So this is just sort of the all-up picture telling you about TrialNet is really trying to save the beta cells at all stages of different diseases with lots of different types of studies. And the way to do this is participation. All the data, the definitions, the idea about what diabetes is all about and the stages, because of all the families that have participated the last 2 and 3 decades of research that's gone on, now is the time that we can take advantage of all that work. Right now is the time that we can now test some of these drugs and say, can we make a difference in delaying this progression? So how can you do it? Well, today, you can go outside in the hallway. There's a picture of a guy, like with his Superman cape. And you can visit that booth, and they will tell you how you can get your family tested today, or if they live elsewhere or other places, how to make sure that people can be tested for their risk for disease. You can also attend the breakout sessions. So wonderful new thing that's happening this afternoon is that you'll be able to have the opportunity to talk to people that are participating in clinical trials. So I think you'll find that very informative to be able to talk to families who are already doing this, because I can get up here and tell you how important it is. And you may know and feel that it's important. It's still a pretty tough decision to enroll in a trial. And we understand that. So we wanted to make sure you had the opportunity to talk to people who have made that decision and how it was a difficult decision in many cases, but what their feeling is about participating. So I would urge you to do that. So I want to thank you. As you'll see here today, we have a lot of speakers from Benaroya Research Institute because we are hand in hand with JDRF. We study immune diseases, and type 1 diabetes is really our main focus here in Seattle. So thank you very much.
Thank you, Doctor. Thank you very much, Dr. Greenbaum. Lots to look forward to in 2017.
Yeah.
We'll be eagerly awaiting the results of those tests, and we'll hope for some positive results. Thank you very much. We have time for a couple of questions. Yes, I see hands up going right away. Do we have volunteers? There's my lovely wife, Gwen, with a microphone. We're going to go right here.
Thanks for your research, and thanks for sharing. What's the longest period of time you've seen stage 3 last?
Stage 3, you mean when the antibodies or once they have clinical diabetes?
From diagnosis to
getting rid of beta cells?
Yeah.
So let me just restate the question. So we know at the time of diagnosis, of course, many people are still making a fair amount of their own insulin-producing cells. And as I noted, we used to say that's completely gone, right? Soon after that. We know that's not true. It depends how old you are. So we did a study of about 1,000 people, right? And we found out that there's about 6% of people, particularly that were diagnosed as adults, that still we can measure some insulin production after 40 years of diabetes, right? It's very different if you're a child. So we still know that if you're an adult when you were diagnosed, 5 years, maybe 50% of people will still have insulin-producing cells. But the amount of insulin-producing cells is very low. So it's not clear yet what we can do with that information to try to make it better for people. But it's very different whether it's an adult or a child. So I think that probably, for 10, 15 years of diagnosis, if you're diagnosed as an adult, a lot of people still have pancreas function, but just not very much. Which is, I guess I should say, so why do we want to preserve pancreas function when you're diagnosed, right? Well, it turns out if you are making your own insulin, you do better. Your diabetes is easier to manage, you have less swings, and you have less complications. So that's really the aim. Even though, unfortunately, we don't yet have something to make those beta cells grow back, that's another whole story. But it gives us the opportunity to make it better for people to live with disease.
Our daughter Allie was diagnosed 5 months ago with type 1 and type 2 diabetes. I'm wondering if that's something you see. Is it very common?
Yeah,
and
so,
the second question is, if you're over 45, how can you be screened?
Yeah. So I'll ask the second one first. So first, I'm sorry to hear about your daughter's diagnosis. It's nice for you to be able to have the opportunity to be in this room where many people share the feelings you're going through. We don't screen people over age 45 for antibodies, not because you can't get type 1 diabetes when you're older. We know you can. People can get type 1 diabetes when you're 60, right? It becomes cost ineffective, right? Right now, we have to screen 200 or so people to get one person who's at sufficiently high risk to be in our studies. We'd have to screen more than 5 or 10 times that many people. So we don't routinely do it because it's just too unusual to happen. Now that's for TrialNet. There are times that Benaroya Research Institute does and are interested, particularly in testing family members when if they have multiple autoimmune diseases in their family, because we at BRI are trying to understand about autoimmune diseases that cross each other. So there may be some opportunities, and you can certainly talk to my team out there. But in general, we don't test for antibodies. That's a risk. So the type 1, type 2 story, that's complicated. In the interest of time, I'll make a short answer, and then we could talk more in the break. The short answer is the distinction of type 1 and type 2 is always mushy, right? And what turns out, we tend to think of type 2 diabetes as, the typical stereotype of a sedentary, somewhat overweight person. And that's not really true either. All I can say, type 1 diabetes by definition means the immune system is evolved in attacking the pancreas, right? That means you have antibodies. There are many people who have the immune system involved whose insulin also doesn't work very well, right? They're insulin resistant is what we call that, okay? And so there are characteristics of being insulin resistant. But in my mind, right, if you have antibodies, you have type 1 diabetes. You may also be insulin resistant, which means there are multiple ways to treat that disease aside from insulin. But it's not that you don't have type 1 or you don't have a mix of those two diseases. But I'm happy to talk more about that at the break.
All right, we have time for one more question in the back.
Thank you so much for your presentation. I'm an example of someone diagnosed as an adult, and I didn't have antibodies, and I don't know if that's because I had them before and got tested too late. But I'm wondering now for my 2 kids, if I don't have the antibodies, does it still make sense to get them tested? And how does that work?
Thanks very much for that question, because again, it's complicated, right? The short answer is yes, please get your children tested. The longer answer is, in the 1980s, when the antibodies were first described, there was just one. It was called islet cell antibodies, and only about 40% of people with diabetes had that. The second antibody, discovered actually by Jerry Palmer at the University of Washington, was insulin antibodies. And if you added that, maybe about 60% of people newly diagnosed. And then about a decade later, GAD antibodies were described. And then a decade later, zinc antibodies were described. So we now know that with classic type 1 diabetes, at least 90% of people will have one of the antibodies that we would measure. There are some people who clinically otherwise seem like they have type 1 diabetes, meaning that you have to take insulin to control your blood sugar, right? There are probably other antibodies that we don't yet know about that would explain that, but we just don't measure those. So I would say that type 1 diabetes clinically means you need to take insulin. Type 1 diabetes, what causes the disease is the immune system that we measure with antibodies. So you probably still have type 1, but we would want to get your family members tested. Okay.
All right. Thank you very much, Dr. Greenbaum. And